form of speed dating. We're going to move through this rather quickly, but an enjoyable episode. So, hello to everyone, and welcome to today's episode number 228 of the Crisis Jam. I'm Dr. Brian Sims. I'm Senior Medical Advisor with NASPID, and I will be your host for today's session. We are featuring today Dr. Jonathan Singer, who, with the help of Shelby Rowe, will be providing our Fireside Chat for today. So we thank you, and we also refer to the chat box when you have an opportunity. Put your thoughts or otherwise in there. Let's move on. I do want to make a few comments about what recently convened was our NASPID's annual 2025 meeting. It was a phenomenal meeting that ended yesterday. And during this time was just a lot of wonderful speakers there, as you see here on the slide, of the likeness of folks from SAMHSA, Dr. Richard McKeon, Tanja Miles, were all present in talking up the wonderful 988 elements through the Crisis Jam and a host of other topic areas related. So it was absolutely.
So that I'm not sure. Yeah, sorry.
That's okay. So this next slide is really just kind of one that all of us as hosts and otherwise really aren't quite sure how it's going to turn out, but just to give you a heads up that this new Crisis Jam, we're going to have a sneak peek of season 6, because season 6 is going to be starting up relatively soon on September the 17th. So be on the lookout for it. Next slide, please. Here's a little clip on it.
From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
And as you can see, it tells you a little bit, but be on the lookout because it's going to be absolutely fantastic. We also want to give you a little preview of what's yet to come, to ask you to join us in Washington, D.C. next year. And this is going to be a combined component that is going to talk about urgent and emergency care in the global summit. And this summit is going to have a number of participants, not only NASPID, but also folks from the Crisis, also from the Global Leadership Exchange, and RI as usual, but Crisis now number 4, what works? So in 2 days, one mission and proving that thing. So we want you to put it on your calendars for July 26th and July 27th. And the global summit portion will be July 28th and the 29th. So it's just mark your calendars for that. Now we had during the annual meeting at NASPID, we had Senator Tina Orwell and Representative Steve Eliasson together, and they had a conversation, and what has emerged from that is actually coming up in season 6, where we're going to put them together, not in a debate format, but just to discuss about battling about the bills that are passed from each section, because both had such incredibly positive components of what they're doing. They're both champions in all that they do. So we're looking forward to that. Next. We are going to, in the new season, come back to giving out Crisis Jam t-shirts during that Crisis Showdown. So we need your help on it. So please, if you will put your suggestions, submit your thoughts, how the shirts would be designed, and just share that with us, because it really will be helpful in us being able to formulate this and get back on board with the volunteerism in terms of the Crisis Jam work piece. Next slide, please. We also want to highlight NRI, NASPID Research Institute, and how crisis bed registries are used to ensure the continuity of care. This is a session that will be held on the, actually today, from 1:30 to 3 o'clock Eastern Time. And we want to give thanks out to Ted Letterman and all the folks at NRI for the amazing work that they do. Next slide, please. We also want to point out in terms of the news, a report from the Seattle Times about how King County is reshaping its mental health crisis response systems. Please check this out. It's going to talk about a number of things that is going to be coming in on the how they reshape their system. Next. Also, the wonderful Huntsman Mental Health Institute, the Huntsman Foundation, who have been incredible sponsors through NASHBID, through 988. They are really championed. They are going to be launching a youth crisis care program. And we're going to be featuring later on, but just for your information, these wonderful efforts that the Huntsman Foundation has been doing regularly. Also, we want to point out that during the annual meeting, Dr. Art Kleinschmidt did speak during that meeting, and he spoke a bit on substance use disorders and gave a lot of interesting data that is helpful in going forward with what has been happening in the realm of substance use disorders. Next. We've reached the Crisis Jam Showdown. I want to make sure that everybody gets on board with this. So please, as we do this, we would like for you to respond as the poll comes through. Now, in accordance with national reports, which of the following is one of the most cited barriers, one of the most cited barriers to sustaining a qualified behavioral health crisis workforce? Remember, we're citing the most cited barrier. Is it a lack of interest in behavioral health careers, an over-reliance on technology for crisis response, inadequate reimbursement and burnout, or excessive credentialing requirements for peer specialists? So if you'll place your votes, let's take a look and see how the audience will fare on this. You guys have been doing spectacular work. Your statistics really are holding up very well. So let's see how we do this time. Is it A, lack of interest, B, over-reliance, C, inadequate reimbursement, or D, excessive credentialing requirements? Let's see where we are. Okay. Well, the audience appears to be almost completely convinced that the answer is inadequate reimbursement and burnout, and you are on target as usual. Thank you, audience. Look at that figure. 92% of you got this correct. And it is something that we really want to take a look at going forward. Now, back to talk.crisisnow.com, just a reminder to all of you that there's a plethora of information available on that site where you can either register for the exam, you can see past episodes, you can take a look at all of the various things that are coming up from the advertisements and some of the things you see on the Crisis Jam, and also announcements about different things that are occurring and upcoming. Also, remember about our YouTube. We do have these featured episodes, and we encourage you to watch them. Go back, check out, because some of them are spectacular in terms of the number of people that have seen them. If you like them, give the thumbs up and subscribe as well. All right. Well, we have reached a point where I'm actually going to, at this point, go into the fireside chat. So at this time, I'd like to introduce the moderator for today's session of Fireside Chat, and that is Shelby Rowe. And Shelby is no stranger to any of us. Shelby, welcome. Shelby is the Executive Director of Suicide Prevention Resource Center. And we're going to turn it over to you, Shelby, and take it away.
All right. Thanks, Brian. I am really excited today that we're going to be visiting with one of my dear friends and favorite people in the field, Dr. Jonathan Singer. When we're talking about suicide prevention, suicide intervention, crisis work, Jonathan literally wrote the book. So please look him up. I wish we had more time to go over his bio. I'll just say he's kind of a big deal. Look him up, and we're going to dive right into some of our questions. So, Jonathan, both of us have worked in the field in different areas. I used to run a crisis center, and you've been training social workers academically and through your podcast for years. And one of the things that I learned is that, crisis can be a subjective term. So let's just start off. I think one of the things that we had in training our crisis line workers, and maybe you've experienced training social workers, is, what is a crisis and who gets to decide what that crisis is?
Well, yeah, Shelby and all the Crisis Jam folks, thank you so much for having me on. The So I think this is one of the most important things to know for folks who are interested in a career in crisis care, right? That crisis is defined by the person, and so what that means is that you have organizations, you have agencies, you have crisis line, you might have mobile crisis response, you might have jobs that don't have the word crisis in the title, but the only kind of client that somebody is sure to have in their career is somebody in crisis, right? And so being clear that your job is to help to understand what is the crisis in the moment, how are they defining it, what does it look like for them, and then how do you respond, really leaning into what it is that they need. And those types of crisis careers, right, can look like a bunch of different things. If you're working at a crisis line, if you're working at a peer recovery setting, if you're doing work doing ride outs with 911, like all sorts of different settings, but understanding crisis is what the person defines it as.
Right. And sometimes, we can listen to their story and we may think one thing is that pressing crisis, but it's something else. And so I think on that of just staying with that person we're helping and meeting them where they're at, and not assuming anything. Also, something that we talked about is how crisis is not a steady state.
Right.
Of different, that there's been a lot of research, and early before we knew a lot, people thought, well, when they were in my office, they were fine. And then 12 hours later, 24 hours later, they made a near lethal attempt. Like, were they lying to me? Or, and I think that's something, on the hotline and I'm sure in person. So crisis, yeah, it's not that steady state. Let's talk a little bit about that.
So I think there are a couple of things with this. One, when we think about folks who are in a crisis, and the crisis is, again, whatever they say it is, you can be in a crisis episode, right? So you can have a couple of weeks where things are going on that you don't really have the skills to negotiate it, right? Either you don't have you've never developed the skills to deal with whatever's going on, right? And so you have to learn some new skills, or you have those skills, you just can't access them because your brain is in crisis, right? And so your prefrontal cortex isn't working, your executive functioning isn't working, you're unable to think creatively. And so folks can be in a crisis state for, 2, 3, 4 weeks. Within any given hour, you might have somebody who is more or less acute, right? And I think that's what you were sort of alluding to, right? So you can have somebody who is in a crisis state, right? Crisis over several weeks. They come into your office and you're talking with them and they present really well, right? Maybe for that hour they're pretty emotionally regulated, right? Behaviorally, what they're saying is in line with what they're thinking and how they're feeling, and you're like, okay, they've been struggling for a couple weeks, they must be good. And then 6 hours later, you check in with them, and everything is a disaster. And I think it's important for folks in thinking about a career in crisis that, not for pathological reasons, but because of the nature of being in crisis, it is reasonable for somebody to present well in one moment and then fairly soon afterwards to not be doing well, or vice versa, which is somebody is like, no, things have been going pretty well, and then they see you and they're completely dysregulated, and And that's also reasonable. And actually, that's a great time to see somebody is when things are not going well, because then you can jump in and really do some good work.
Right. And I think, that's really important when we're looking at crisis work, because that first encounter, if it's on the phone or at a mobile crisis, they may be completely dysregulated. And then at the next step, um, be presenting, of much more calm and see more together. And so to not minimize. So that's why I think it's great of relying on those standardized screening tools and things like that, because you can get a false assumption. I think either way of someone who is appearing so dysregulated and thinking, oh, they must be experiencing, a state of acute psychosis and things, or someone who is presenting very calm, articulate. Um, do your assessment tools. I think, because that affect for each of us, our bodies just can't maintain that level of acute distress. It is exhausting.
It
Uh,
is exhausting.
yeah, it's an exhausting state. And so, yeah, knowing that the people in crisis, coming in and out, it doesn't minimize, if you catch them at a good moment when they've caught their breath, that doesn't mean that they're not still acutely at risk. Um, and going with that. But yeah, I know that we've had so many conversations about that. And I know that for me, when I was in a state of crisis, that led to people minimizing my risk because I presented very calm, just because that's my personality. um, I'm going to present that way. And so knowing, the importance of using those tools, because how they're presenting to you, that state can change, 20 times in a 24-hour period.
Well, and I think this is such a good point for folks considering a career in crisis care, right? Because if you are somebody who uh, doesn't like things changing rapidly, maybe a career in crisis care is not for you, right? And there is plenty of work for everybody. Let me just say that, right? So, when I was doing mobile crisis response with children and adolescents in Austin, Texas, right, we'd get phone calls from the hotline, and they'd say, "Hey, there's a 9-year-old at the emergency shelter who talked about killing herself. We need you to go out." So we'd go out, right? In that suicide risk assessment moment, right? We had one job. We had to understand the level of risk for immediate harm to self, right? We had to make sure that we were doing that job. And as we were gathering information, that's when we were able to think to ourselves, although we wouldn't necessarily talk about with like a 9-year-old, but what are the other issues that underlie this, right? That surround this. And so what are the other resources that person might need? And so when we're thinking about the idea of crisis treatment as different from therapy, right? The therapy is what can address the long-term issues. So you had this 9-year-old who had been experiencing ongoing sexual abuse. You had she was suddenly she didn't have her family around, her parents, her siblings were separate. These are a lot of things to talk about. Can't do it in a crisis situation, right? It's not the time, it's not the place. And so as a crisis worker, understanding that your knowledge of the system and the resources and referrals is essential. It is just as important as any skills that you have. And by the way, I just want to be clear, when I talk about the difference between crisis work and therapy, I'm not suggesting that people who see themselves as sort of outpatient therapists or who do long-term therapy aren't going to be doing crisis work, because they absolutely are. Because as I said earlier, everybody shows up in crisis at some point or the other. But there is a difference in terms of what you're able to focus on. And you use the skills that everybody is trained to have in terms of empathy, in terms of being able to problem solve, in terms of being able to coordinate care. You use those in a different way in crisis services. So yeah. So anyway, the difference between crisis services and therapy, I think, is an important piece for people to remember. And it's okay if the long-term therapy side is more your jam, right? Not everybody's jam is the crisis jam. I had to throw that in there.
That's a very good pun. Um, but yes, and I remember, at the crisis center, we had a social work grad student who went through our crisis line training and they were very excited. And they took 3 shifts on the crisis line and like came to me and said, I can't do this. Like, I thought I could do this. I've been doing my training. They had done other, they're like, I can't do like phone crisis care. And it's like, well, I'm glad that you recognize this now. It's like, let's do, found her other things she could do to finish out her time with us to keep her off the line. But yeah, of knowing that about yourself, because, just as in medicine, we look at people that are MDs, an emergency room doc is very different than a primary care physician. And our system needs both. And so I think that of knowing, if you are, treating someone, if you are, someone working in an outpatient clinic, I think sometimes it is really challenging to recognize this is shifted from our usual therapy appointment and our long-term goals. This is shifted to a crisis intervention. And I think for you, any tips or things of noticing, you get in a conversation, because at that point, I think you do have to set aside what are those long-term treatment goals and then focus on the near immediate. Like, how do we get you through the next 24 hours? How do we get you through the next week? And to kind of shift gears, kind of what would be some tips for someone young in the career of things to know, like, oh, today is different. I'm gonna, our priorities are very different than what I thought they would be.
I think one of the things that's really important for folks who work in crisis is to understand that your time frame is minutes and hours, right? Not weeks and years. And so um, I remember I started doing this thing both to take care of myself, but also to be grounded in the moment, which is when I would walk into my office, knowing that there was a family there with a kid who was suicidal. I would take a deep breath. I would be standing outside the door. I would take a deep breath, put my hand on the handle, and I would open the door. I would exhale, and then as I was walking in, I would inhale. So I'd bring in the moment, I'd bring in the room, I'd be physically grounded in the moment, right? And so it was a way that I could be present in the moment. That was what was most important, right? And so when we think about some tips for folks, one of them is you have to have some tools at your disposal for staying grounded. Right? So whether that's having a mindfulness practice, practicing your deep breathing, having something on your desk that you can look at that grounds you, right? I've got this little bag that you gave me that's got like a marble and a ball and a dinosaur and things like that, right? So to have that, to know that your colleagues are sometimes the only people that you can really blow off steam with, because they understand what you're doing and what you're going through. You can't tell tales out of school, both for confidentiality reasons, but also sometimes you just sound like an asshole if you're complaining about work with people who are not doing this work, right? So you have that peer support in terms of your self-care. And then I would also say that there are some very basic skills that are important to know. And David posted in the chat something about the podcast. So I started a podcast back in 2007 called the Social Work Podcast. And the third and fourth episode, right? So January 28th, 2007, were all about crisis work because it's so foundational and so important. And being able to understand what we were alluding to earlier, which is when you have somebody that's emotionally dysregulated, right, affectively dysregulated, that one of the techniques is to get them thinking, right, to have them enter their cognitive space, right? You don't want to have them close their eyes and deep breathe and get more emotional, right? So these little things, right? These are things that all of us that are on this call that are in crisis work, we know this, but you can actually learn these and practice them so that when you're in the moment, you can pull up those skills, those tips and tricks.
Yeah, and that, what I want to talk about is those tips and tricks of the self-care of being in crisis work. It is different. I think a lot of a lot of my team referred to it as kind of being an emotional fireman. Like one, you've got some downtime. It is not like TV, right? It's not like watching, a crime drama, where they're at the hospital and everything's super fast paced. Um, there may be, sometimes a person in crisis needs to take a nap and you need to be there and be around and follow up to make sure, that things are going to be okay. But, we had talked with our folks, we use the analogy of wringing out your sponge of, when you're in a crisis intervention and you're listening and you're doing all those active listening and empathetic, you're helping hold that burden. You're helping hold whatever is too heavy for them so they can process. But then equally important is the skill of being able to put it down. And so with my volunteer, we did the example of like, if your sponge is full and you put it in a new thing of water, like it's not going to absorb anything. So how do you wring out your sponge? And you shared some of the things of self-care. I do bead work. I have like little random bags of beads on my desk of like, oh, let's think of, different ideas. What am I going to do with these beads? Um, what are, some things, because I think we can, the main reason people leave the field is burnout. And so definitely want to wrap up our session today of someone who's been in the field, for a while and, hosted the podcast and you've consistently stayed inspired and motivated. What are things people can do to prevent burning out?
Well, I think one important thing, and this is part of the the zero suicide framework. This is part of sort of a philosophy, which is that burnout cannot and should not be the responsibility of a single employee. Right? It is an organizational effort. It means that everybody's going to go out there and do the best they can. Right? So, as a crisis worker, I need to commit to that. I need to show up to work and say, you know what, today I'm going to do the best that I can. And when mistakes happen, when I make mistakes, when I do something I shouldn't do or don't do something I should, I need to be able to know that the organization is going to support me. And that will prevent burnout because then it's a team effort, right? Like I said earlier, obviously mindfulness, doing things, having somewhere to go hiking, if that's your jam. Sitting on the couch watching a movie with your kids, if they can agree on a movie, which sometimes it doesn't work, but that's a whole nother issue that we can talk about in therapy sometime. But having things that work for you, I think, are really important to prevent burnout. The other thing that I'll say is, and this is more on the individual side, because a lot of folks are like, okay, great, so the organization needs to do it, but I don't control the organization. I think being very clear on what your goal is essential. So when I started working with suicidal kids, people were like, how can you do that? And what I learned is that working with suicidal kids and their families is actually the work of hope. It is about finding the part of them that wants to live, acknowledging the part of them that doesn't want to live, and growing that part and building up resources. And that hopefulness actually is burnout prevention, and it's also good crisis care.
Well said. I have no notes, nothing else to add to that. Thanks so much, Jonathan, for joining me today. Always a pleasure to talk with you. And I know that you dropped a lot of gems of wisdom for everyone.
Love that. Thank you, Shelby.
I would like to chime in to thank you both. I think if you've been monitoring Dr. Singer as you have the chat box, the number of comments that have already placed you guys as a fertile team that can be looked ahead. They really enjoyed the conversation back and forth, but also the wealth of information that was shared. So I want to thank you both for that wonderful feature presentation. We're going to move now to our roundtable discussion, and we're going to start off with Heather Gaylord, who's the Director of Healthcare Initiatives with the Suicide Prevention Resource Center. Heather, your comments on today's feature presentation.
I just want to say first, thank you for having the conversation. I think it's so important to offer space for folks thinking about getting into this work to kind of get a preview of what that might look like and understand what they're getting into. I think a lot of the work that we do at the Suicide Prevention Resource Center leads into these discussions about how do we ensure that we're really prepared for the work that we're doing, that we feel informed, and that we're able to do this work with care, not only for the people we're working with in crisis, but also for ourselves. So the conversations around burnout just really resonated with me. And I did see that someone had posted in the chat, just are people coming into this work, whether they're graduate students preparing to enter the field for the first time or already in it, really prepared to do this work. And I think education is something that's a part of all of our commitment when we go into the field, regardless of where we land, and finding resources that can help you with that. Today we're very fortunate at the Suicide Prevention Resource Center to be launching, in good timing with this discussion, our Suicide Risk Assessment Toolkit, which really offers a way for folks to look at what is practical application of suicide risk assessment? How do I go about having those conversations? What might be those ethical considerations that come up, right? Some of that anxiety about doing this work. Am I going to do a good job? How do I care for the person while caring for myself? And so I really just encourage people to check that out and to carry these conversations forward. And supervision, I think, is a huge part of us staying whole in this work. And so always seeking that consultation as well.
Well, thank you so much for that. And again, we want to reference the chat box. So please go in there and click on the link there. And I'm sure Heather, you, and as well as anyone else, are available for any questions that anyone might have, or any kind of resource references. So we thank you so much for that.
Thank you as well.
And I want to move now to Dr. Lena Hyman, the suicide prevention and post-prevention advocate with sibling suicide loss survivor. Dr. Hyman, welcome, and thank you so much for being part of the roundtable. And please go ahead with your comments.
Yeah, thank you so much for having me, and thanks for inviting me to this discussion. I thought it was incredibly helpful. As I was listening, I was really thinking through some different lenses. So I wear a number of hats in suicide prevention and post-prevention. And regardless of which role I am professionally sitting in or whichever volunteer work I'm doing, I do this work as a sibling suicide loss survivor. And I know that many of us enter this field because we have at least one why that is driving our work. So it might be our own thoughts of suicide, being suicide attempt survivors, our own struggles with mental health, supporting family members, or experiencing the loss of a family member, friend, or community member. And as Jonathan was talking about burnout, I was thinking a lot about the different ways that my own lived experience can show up in the different roles that I have, and how to be really thoughtful about what my own triggers are or what might activate me, or being really thoughtful around where am I at today and what might bring me to a place of being less receptive to somebody else's struggle, and really being thoughtful around what do I need to also take care of myself. And one of the techniques I've done over time is if something is stirring in me in the moment, but it's not the right moment for me to center myself, I make myself a promise that after this conversation or this hour or this period has concluded, then I'm going to return to that emotion that came up for me and really give it the care and attention that it needs. So as I was listening to this conversation, I just kept reflecting back on what does it mean to have lived experience in the field? How do I support myself? And by supporting myself, continue to support other people. And part of that support is also not just taking care of myself, but what also stuck out to me is having a network of people who understand. So for me, having people who are also sibling suicide loss survivors has been integral in maintaining my trajectory in the different components of this field. I know that other sibling suicide loss survivors, other loss survivors understand the differences of my emotions. And so whether they are professional colleagues or friends or family members or people I've met through survivor networks, it's really important for me to be able to connect directly to people who share lived experience so that I also have that support. And then finally, I really resonated with the idea of hope. And one of the paradigms that's really resonated with me throughout my decade plus in suicide prevention and postvention work is that so much about suicide is ambivalence. I think Dr. Friedenthal also talks a lot about ambivalence in that when someone is suicidal, we're trying to decide what are the reasons to stay alive and what are the reasons to die, and trying to identify where are the messages of hope and to understand that that ambivalence is very real and that means that there's still an opportunity to continue to stay alive, whether it's a choice for the next little bit, a stay safe for now, or it's a longer term commitment to staying alive. So all those pieces were coming up for me. I really appreciate this discussion. I love reading the chat, and thanks again for having me here today.
No, thank you. Dr. Howman, if you would, Dr. Singer put in the chat box your book, and could you raise up maybe a few elements about your book? It sounds, as Dr. Singer pointed out, it sounds amazing. I haven't had the opportunity to read it, but
well, thank you. Thanks, Jonathan, for putting that in there. When I first lost my sister Danielle to suicide, I was absolutely shattered by the grief and didn't know how to survive. And I quickly connected to other sibling suicide loss survivors. I found pieces of my own story reflected in theirs. And I found that it was one space where I could say anything and not be met with any sort of judgment, just so much understanding. What also really connected with me early on in those first days, weeks, months of my loss was knowing other people who are further out from me. So when I was a few months into my loss and I was like, how can I do another day of this? If I talk to somebody who's 2 years out from the loss, that shifted something in my body where I thought, I don't know how I'm going to get to that point of being 2 years out, but I'm talking to someone who's done it. So the book here is an edited collection of sibling suicide loss survivors. I see some familiar names on the chat too of folks who've contributed essays to this anthology. So thank you so much. And for me, it was important to organize it by chronology out for time period of loss, so that mirrored my experience of talking to people who are recent and also being able to talk to people who are 30, 40 years out. And from that, I was first able to finally see that I might be able to survive this devastating tragedy, not just for the next day or two, but there might be a longer term future for me because other people are doing it too.
Well, thank you so much for that. And what resonates with me is just the connections here that you guys have. It seems that the three of you together really promote a message that we all need to hear. And thank you for clarifying a lot of the issues there. Spoken from lived experience is one of the most profoundly positive and powerful ways to really get to a message to each and every one of us. So thank you for sharing that with us. And thank you again for the book there. I noticed that they did put it in there. And so not a shameless plug, but Amazon does sell it. So, hey, let's go for it. But again, thank you so much, Dr. Howman. And thank you as well to Shelby Rowe. And thank you, Dr. Singer, for an absolutely wonderful presentation. We have carried so much from it. It took a lot of notes during that time, but clearly this is something that reminds us to a large extent of what things really got us into the field that we are in right now? What were some of the passions that we carry and some of the outcomes that have been there? So thank you all, being the folks on the line, for the interesting questions and so forth placed in the chat box. So I think at this point, we're ready to move over to our SAMHSA update. And we have with us today Bethany Myers, who is the Public Health Advisor with SAMHSA. So Bethany, take it away.
Hello, thank you so much for having me on. My name is Bethany Myers, and I am a public health advisor in the CMHS branch of SAMHSA. And we do lots of great things here. And I want to say, one, I know you all have talked about the Nashville meeting, and SAMHSA had a wonderful time. We had a couple of speakers there. They were absolutely thrilled to be there and do. They said everyone that came back said it was a phenomenal meeting. So thank you for having us there too. And the big update I wanted to talk about was last week when Richard was giving the update, he was live at a policy academy. And that policy academy was actually being run by me. And also a lot of our CCBHC team, as well as some of our 988 team. So it was a big collaboration effort. And it was the Rural CCBHC Crisis Systems Mapping Policy Academy. So we focused on rural crisis systems. We had 6 CCBHCs joining us from a variety of different states all over the nation. And they got to meet with and hear from experts in a wide variety of subject matters. And all of the experts presented on a wide variety of topics, from workforce to financing to rural crisis solutions to all kinds of different things. And then the teams met with facilitators for several hours throughout the 2.5 days. And they got to plan the next steps of their crisis system. So obviously every crisis system has gaps, and they went over their crisis system and made the next steps of how are they going to improve it. And it was a phenomenal event. And our lovely host, Brian Sims, was actually one of our experts there. And the teams worked so diligently. One of the teams told me they went out in the evening to get dinner, and I think they were doing Topgolf, and they were working on their plan the whole time. And they got there early in the morning and worked on it. I mean, they were nonstop. I went to go check on the teams, and I scared one of them because they didn't see me walk into the room and they were so focused. And they were just so just passionate about fixing their crisis systems and improving. And each CCBHC got to bring some of their local providers and team and people on. They got to build their team to bring with them. And we had CCBHC staff, we had local law enforcement come with them, we had hospital providers, we had state representatives. We had people that represented their call centers. We had all kinds of people join them, and just so much shared expertise was just going between everybody, and there was so much collaboration. It was a absolutely wonderful event. And so if any of the teams are on here that were able to come, thank you for coming, and I hope to present about that more one day. But I just wanted to let you know we had a wonderful event, and Richard and Brian were at the event, and they were great. But everything else, that's all I have for the SAMHSA update. So thank you.
No, Bethany, thank you. First and foremost, for all that you do and all that SAMHSA does in terms of maintaining these policy academies and how critical they are. Because clearly, Bethany, one of the leadership pieces that we saw in working with the teams is that they all look to SAMHSA and look to you for that guidance about what next steps are there. So I couldn't agree with you more. It was an absolutely outstanding event with a lot of individuals that were working cohesively, and many of them had just met as a team for the first time, which I think is some of the points we make in 988 and movement here about making sure that teams get together to collaborate. So thank you so much, Bethany, and looking forward to future policy academies as well. Now we'll move to our Nashville update with our own Dr. Brian Hepburn. Dr. Hepburn, please.
Thank you, Brian. So as people have mentioned, we had our annual meeting. It was really nice. It's nice to see everybody. And in a way, it was like 3 days of 988 Jam, having content experts from all over the country focused on 988, crisis services, CCBHCs. But also, we discussed other topics like updates on SED, updates on SMI, updates on state hospitals, other topics, addressing maternal mental health, addressing grief and loss, topics like homelessness, forensic issues, AI, digital mental health. And if you would like to see, if you would be interested in seeing the video, let us know. And maybe not today, I don't think we have it set up yet, but it's in the next few weeks, we can give you a link so that you can see it. But one of the areas that I wanted to thank Bethany about was the fact that SAMHSA was there, Arthur Kleinschmidt and his team. It was very comprehensive, very inspirational, and we really look forward to working with SAMHSA over the next few years. SAMHSA has always been a strong supporter of ours and the states and territories. So we look forward to continuing that. We also recognize that we need to look at funding elsewhere. So one of the areas that was explored and discussed more than what we have previously is what can we do better when it comes to public-private partnerships? And we had several sessions on this, and it was very helpful, I think. You know, when we look at the sponsors for our event, you know, that's public-private partnership. We would not be able to set up our meetings without our sponsors. And yet I don't think that we give them enough attention or that we make them aware of how important they are. I can't name all the sponsors, but I did want to name a few. Huntsman Family Foundation, NetSmart, RI, Behavioral Health Link, AHP, Carillon, Pew, Bamboo Health, Beacon, Connections, Health Management Associates, EY, TBD Solutions, Solari. You know, these are all names that you hear over and over and over again, but we may not be giving them enough attention. And that was only half of our sponsors, right? The sponsors end up being so important. And I think you'll see that, as David mentioned earlier, as we go forward with the JAM, I think you'll see that private-public partnership explored even more. One of the areas that we've done so well on over the last 20 years is what is called the Transformation Transfer Initiative. That is within Nashville. And what that has done is we've set up these pilot projects with the states. And in the pilot project, we would have our experts going in and helping the states to develop those areas that they're interested in. Why is this important? Well, it gives states the opportunity to develop an expertise in an area, a location, an interest area. And then they take it to scale. It has been such a nice program. However, we've lost funding for that program. So one of my appeals is if there's anybody on the call that's looking for a great project to fund, let us know. We'd be very much interested in exploring that with you. That's just one example. As we go forward, we're going to have to do more to help the homeless, for example. That can't be done with just the public sector. There isn't the funding. We really need to pull some philanthropic organizations, some private companies together so we can really move forward when it comes to improving the lives of people with mental health problems, substance use problems. We can do better. And I think we're not maximizing our effort until we're getting full involvement by private sources. We've tried for so long to do it with just public funding and slowly moved in with private funding. We need to do a better job there. And so it's something that was explored in our meeting, and I wanted to share with you, and I thank you.
No, Dr. Pepper, and thank you. Thank you for your leadership. Thank you for where NASPED has been going. Thank you also because of the acknowledgement that the sponsors were really at the highest number we've ever seen. But that's a real story behind it that says that there are more organizations that are vested in this type of work that we've been doing. So thank you so much for that. And as we move ahead next, we are going to our Medicaid front and center. And we have with us Tom Betlock. And Tom, if you're available, come on board and we'll take it from there.
Thanks, Brian. It's good to be with Crisis Jam today. I was hoping Dr. Singer would provide the secrets of how to find that movie that we can share with our kids. I'll look for that next time in terms of the secret around that. I'll share a resource that I was going to speak to that I'm going to speak to today. And really I wanted to talk about is now that the dust has settled in terms of the passage of HR1, there it is. Thank you, Karen. I just wanted to spend a minute or two, I've only got a couple minutes, highlighting the Congressional Budget Office's scoring on the Medicaid impacts associated with the policy changes in the legislation. And it's around $1 trillion in reductions over 10 years in terms of impacts associated with the changes that were in the legislation. And the thing that I just wanted to note so that people understand and take away is the majority of those dollars lie in 3 different policy areas. The one is the work requirements for individuals that are part of the adult expansion category from the ACA, and that starts on January 1st, 2027. And so states will be working to implement that, and states will be awaiting guidance from CMS and regulations, and all that will play out. But the other 2, I think, are pretty complicated and not necessarily straightforward in terms of their potential impacts. And that is the provider taxes. And you see the dollar amount there. It's almost $200 billion in terms of impacts over 10 years. And then the other one is state-directed payments that states use to provide supplemental payments, largely to hospitals. But the thing that I really want folks to take away from is this is the 10-year impact of how these different policies get phased in. And so the thing to note is that, roughly 20% of the cuts are in the first year, or the 20% of the impacts. And then, the remainder is in the out years. So I think one of the interesting dynamics that you will see here is that, ongoing, there'll be continued discussions around Medicaid financing policy at the federal level, and that, there's going to be interest from states and other stakeholders in terms of, continuing the discussions around some of these policy changes, because they're really not phased in until several years from now. And so you'll see states starting to identify what the potential impacts are, but many of those impacts are in the out years. So states will be adopting annual budgets. We'll see what happens as it relates to future congressional changes. But the one parallel I would make is that several years back, Congress made changes as it relates to physician reimbursement in the Medicare program. And for a number of years, they made policy decisions to sort of suspend those impacts. We have no idea how the Medicaid discussion will be playing out, but it is important to note that with many of these impacts being in the out years, one could anticipate ongoing policy dialogue as it relates to Medicaid financing at the federal level to play out extensively. And so I would just highlight this to folks. I know that there's been a lot of discussions in terms of, what was in the legislation, but I think it's important to bring forward the CBO analysis and really look at the impacts by years and have an understanding that much of this is in out years and how that's going to play into the ongoing policy debate. So, Brian, it's hard to do that topic justice in 4 minutes, but I really just wanted to present the resource and let folks sort of take away that nugget that, this is going to be an ongoing discussion as it relates to states and how they think about this and working with federal partners.
Tom, I have to be honest with you. I hear what you're saying, but I wasn't thinking that at all. I was thinking more so that thank you for making it plain, because this is, the HR1, everyone knows about it, but to unwrap it in 4 4 minutes or whatever is just amazing. Thank you.
Yeah, well, I'll thank all the great people at CBO that spend a lot of time, doing this tireless work in terms of doing these estimates and everything else like that, and presenting that information to Congress and stakeholders. But it's out there, and so I would encourage folks to take a look at it and have an understanding of how this plays out over many years.
Thanks again, Tom, for all you do. I will now move to the federal updates, and we're going to start, I believe, with Emily.
That's right, Brian. I am here.
Heidi, please.
All right. Great to see you all again. I know it's been a little while since Sarah and I were here together to provide a federal update. And we are glad to be back with you all, especially as we are just about to head into August recess officially next week. A couple updates for today. We did want to provide an update on federal funding and appropriations, since we've talked about that several times recently, and we'll continue to talk about it moving forward. This week is timely, as tomorrow the Senate Labor HHS bill is scheduled to be considered by the full Senate Appropriations Committee. So that's tomorrow morning. And this, for those who don't follow the approps process very closely, is when the Appropriations Committee will include the text of the bill, will consider the text, and this is the bill that includes funding for 988. So I know many of us are carefully following the Labor HHS bill for that, and likely for other important programs as well. With the markup, we do expect hopefully to see the draft text soon, assuming the markup does happen tomorrow. It's still scheduled, but you never know. There could be shifts in that schedule. Once we have the text, we'll see whether the Senate bill includes that number of $520 million that was in the president's budget request, matching the previous year's funding for FY24, as well as the CR for FY25. Or if it includes a different number, and any report language that we'll see, and be analyzing that and see where the Senate is landing. As for the House markup for the Labor HHS bill was originally scheduled for this month, but the House has already gone on their August recess, and that consideration of the bill has been punted to September, which does give us, as advocates, for those of you on the call who advocate for funding for 988, a little bit more time to do that over the next several weeks and through August recess. We wanted to just provide an update on the reconciliation bill, just to kind of touch base. Tom just provided such a great update and ideas for next steps and things to follow, and the CBO analysis. So really all I'll say about this is, yes, the bill passed. It was enacted into law. The American Foundation for Suicide Prevention, which I am in our policy and advocacy office, we put out a statement denouncing the Medicaid changes. The Mental Health Liaison Group and other organizations also did, really calling on Congress to reverse course and protect access to Medicaid. And I know many groups out there are continuing analysis and advocacy and other actions as well over the coming months. Now I'll turn it over to Sarah to continue today's update.
Thank you, Emily. So we've got a change on the House side. It's the committee, the authorizing committee for things such as Medicaid, the Public Health Service Act programs, 988. So they don't set the funding, but it's the authorizing committee that has jurisdiction over a lot of these important health matters. We wanted to note that there is a change in leadership that was recently announced for the Energy and Commerce Committee. The Health Subcommittee specifically has a new chairman. It was previously Buddy Carter of Georgia, who has stepped back from that leadership role. He's running for a different office at this point. So the new chair of the Energy and Commerce Health Subcommittee is Rep. Morgan Griffith of Virginia. Since it is a Republican majority in the House, he's a Republican member. He is the new chair of that subcommittee on health, which has jurisdiction over a lot of these important matters. So just wanted to flag that change. And also, as Emily referenced as well, next week is the official start of the August recess. The House is out at this point, but the Senate is wrapping up things this week. As kind of per usual, they will be out all of August until usually the Tuesday after Labor Day. So it'll be likely a little bit quieter coming from DC updates, but we'll be back after Labor Day to update you on anything that's happening at that point. And as always, if there are any questions, please put them in the chat. Thank you so much.
Thank you. And thank to both of you, Sarah. Thank you, Emily, for that information. So helpful as we're guided along each day, it seems, with the policy changes and with keeping us updated. Thank you so much for that. So as we draw close to today's 228th session, we want to remind you, coming up next week, live and on location. So look forward to that with follow-up and funding the SLC Crisis Center. And then in 2 weeks, we will have episode 230, Public Perception of 988, Insights from NAMI's National Poll. So we have a lot going on, so we're looking forward to having each and every one of you with us, and we thank you so much for joining us in today's Crisis Jam.